Evening all to the 124th session of the weekly huddle. I am Anoop, and joining me today is my friend Praneeth. We both are cardiologists working at KIMS Hospital. A short introduction to the huddle. It is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily clinical practice. We typically pick up a topic or a clinical case, and we try to restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussions to a little bit more organized platform like what we are trying to do today, and share our ideas as if we would do it in our regular clinical practice. While we do welcome science and guidelines, but with the huddle, we intend to help a physician translate established medical knowledge into common clinical practice, taking local factors and practice patterns into account. So a more of a pragmatic model rather than an algorithmic model. This is not a speaker and an audience model rather than a very casual interaction, which means any one of you at any point of time can unmute yourself or put in your questions or suggestions either in the chat box or raise your hand and I will give you a chance to speak. As a courtesy, you should always wait for others to finish their thoughts before you unmute yourself. To assist in today's discussion, I am joined by two of my guests. We have Dr. Arvind Panda. He is a senior urologist at KIMS Hospital. And we have Dr. Sridhar Reddy with us. He's a senior nephrologist at KIMS Hospital. So we will take their opinion as well. But I would urge all my attendees, like what we have been doing before, that just because we have got experts present here, that should not preclude you from sharing your thoughts. At the end of the day, we want to discuss what we do in our practice rather than what is written in the textbook. So I will briefly mention the case for today, and it's customary for me to initiate my discussion, taking my co-host Praneeth's opinion first, and then maybe I'll ask the attendees to give their opinion. And we will go to our experts after that for whatever mistakes we have made and how we can make it better. So the case for today is a 64-year-old female. She has a history of diabetes and hypertension. She also has coronary artery disease, for which she underwent angiogram a few years ago. She had non-obstructive coronary artery disease, mostly related to branches, and she had been put on medical management ever since then. She did undergo thyroidectomy long time back for what seemed to be goiter. And since then, she had been on thyroid supplement, which she had been taking religiously. And her thyroid seems to be pretty much in a normal status right now. So she comes to my OPD for a routine visit. She does not complain of any active cardiac problem. Her metabolic parameters are all within optimal range. She does complain of urgency, frequency, and burning micturition on and off for the past 1 month. She does not complain of any fever. She does remember that she was treated for UTI a couple of months back for similar symptoms. Her symptoms kind of goes on and off. She thinks that treatment probably makes her a little better, only to have a recurrence again. Her physical exam in the present clinical encounter is within normal limits. Her medications are pretty normal, what you would expect for a patient with her comorbidities. She takes a statin, aspirin, sitagliptin, metformin, thyroxine, multivitamin, a PPI, which she takes once a while, telmisartan, and occasional Ultracet for knee pain. Her hemogram RFTs are unremarkable, and lately she did undergo a complete panel, which included TSH and sugars and everything, and they all were within normal limits. Her complete urine examination showed 8 to 10 pus cells. There were no bacteria present, and there was 1+ protein in the urine examination. Based upon this, I started her on a 3-day course of amoxicillin clavulanic acid, treating an empiric UTI in a female, so essentially treating a non-complicated UTI. I did obtain a urine culture before I put her onto antibiotics. So she did take 3-day course of amoxiclav. She reported me the urine culture after 4 or 5 days, which was noted to be sterile. As instructed, she came to me after 2 weeks of follow-up. After 2 weeks, she says that her symptoms are more or less the same. It has not changed much. She's waking up about maybe 4 or 5 times at night, and also during the daytime, she has urgency and frequency both. As I said, the urine culture is sterile. I repeated urine examination at that time, and it also showed persistent pus cells. So now I'm dealing with a patient who has got at least 2 documented evidence of pyuria in the urine, with the urine culture being negative. Now we know the urine culture can often be negative even in the presence of UTI, who did not quite respond to a 3-day course of antibiotic. And now she's here looking for further opinion. So I'm considering it as a sterile pyuria, although we will discuss about the strict definition around it. And what I want to highlight in today's discussion is what are the pertinent aspects of the history that we should be talking about, any physical findings that a non-urologist or a non-nephrologist should be able to pick up, and basic lab assessment for clinical presentation. What should be the differential diagnosis that we should be thinking about, and when to seek expert help. And here I do want to highlight that this is a request to my experts here, that one of the premise of discussion in the huddle is to kind of share knowledge which for that particular subject is something which should be expected from doctors across the field. So we understand that after a certain limit, after a certain phase, these entities, they should be treated with experts. But as a doctors, we all should have basic knowledge of most of these entities. So our main focus is to discuss on those basic aspects of the topics that we bring up, like today's topic being sterile pyuria. So I'll start with Praneeth. Praneeth, if this patient comes to you, this is her second visit now. Her rest of the parameters are okay. Diabetes is well managed. Coronary artery disease is well taken care of. She's having these little bit of pus cells in her urine, but she has got some symptoms, and she has failed a 3-day course of antibiotics. What to do next? Where are you going to take? And then we will ask our other attendees for their opinion. Praneeth.
Yes, Anoop. So first thing is symptoms versus no symptoms. If the patients were not having symptoms, that seems to be another topic probably. But because this patient has symptoms and you find pulses, so making a diagnosis of urinary tract infection seems appropriate, and giving a short course of antibiotic is also fine. Urine culture is negative, and equally the response to the antibiotic also seems to be suboptimal. She being diabetic, she has a risk of progression of these diseases. So I would be what you call more careful in making sure that urinary tract infection is completely tackled. So possibilities, what I think here is one, why did we not get a culture report? Either the probably most common thing I would see is sample collection probably was not appropriate. Considering if the sample was appropriate, either partially treated infection where probably there was no growth, and second thing, non bacterial infections. Now, when we talk about non-bacterial infections, probably we can start with viruses. Less likely that viruses can produce a urinary tract infection. Then parasitic, the so-called this gonorrhea or non-bacterial like fungal infections could be one possibility. She being having diabetes, fungal and parasitic could be one possibility. That is what I could think of. Now, for clinical signs elicitation, I probably, other than checking for her loin tenderness, I don't think whether there is any other clinical sign which will probably help in making any further assistance, in my opinion. I would try to investigate her. So I would try to see her entire system, starting from kidneys to lower down. So I would ask for an ultrasound abdomen to see whether there is any obstruction anywhere, or whether there is any stone, and equally whether to see whether there is any renal involvement. Uh, Regarding antibiotic, I would try to see whether the infection is strong enough that oral antibiotics are not sufficient, or probably the duration is also not sufficient. But because she has diabetes, I would be having low threshold to escalate the antibiotics probably from oral to IV, and maybe even consider giving stronger antibiotics, simultaneously investigating the other possibilities. Do I need to refer to any specialist at this point of time? Probably I will wait at this point of time. Maybe I'll look at least the basic set of investigations, particularly ultrasound. If I find or ultrasound or any derangement in renal functional status, like rise in creatinine or any other issues. So if either of these things show any abnormality, then I would refer to a urologist or a nephrologist. Urologist, particularly if there is any problem, if which I can see that he or she can address in the form of any stone, or if there's any evidence of pyelonephritis, etc. And if there is any renal dysfunction, probably I may take help of a nephrologist to see need for any renal replacement therapy in view of any renal dysfunctions. Otherwise, currently I do not see how it makes a difference in taking their opinion. I would be willing to learn from them today. I think these are the comments from my side, Anoop. This is what I can think of at this point of time.
So Praneeth, few questions to you. You mentioned changing the antibiotic. Now walk me through it. Let's say this patient is there with you right now. I understand you are saying ultrasound abdomen you will do. Walk me through. If you are writing orders, what are you going to write? IV antibiotics means, are you going to admit her, or you are going to give it at home, or you are going to change something to a stronger oral antibiotic?
I will give this patient intravenous antibiotic, and these days I believe if she stays in city, then we can manage giving her antibiotics in the city with these home care services are quite easily available these days. So I would probably give her a broad spectrum antibiotic like ceftriaxone, 1 gram IVBD for this patient. While I wait for the reports, I will also ask a repeat culture, and also would suggest to get a repeat urine culture again to see whether it is there, and ultrasound abdomen and renal function test.
Okay, thank you, Praneeth. The forum is open for discussion. If anybody has got any questions or any comments before I reach out to my guests for today, if anybody has got any opinion about what they would do differently, you can unmute yourself and share your thoughts. So let me invite Dr. Sridhar Reddy, sir. Dr. Sridhar might be in his OPD right now. Sir, if you are free, could you please unmute yourself and share your thoughts about cases like these?
Good evening, everybody. Yeah, quite a. I'm Dr. Sridhar Reddy. Quite an interesting topic, Dr. Anoop, which we quite frequently see. So there are a few things which I have heard through the whole of this discussion till now, and I get to hear that this lady has had decent diabetes control. One of the causes for occasional burning sensation while passing urine or increased frequency is many a times uncontrolled diabetes, or if it is suboptimal. So I hear in this lady that diabetes is under decent control. One of the most important thing that we would like to ask is, in this lady, if she's undergone hysterectomy. Many a times that is one of the commonest reasons that women will have this increased frequency or a burning sensation while passing urine, simply because they will have dry genitalia, mucosal lining. So first, and that is one of the most important aspects in terms of asking in the history about hysterectomy status. And one of the other reasons many a times will be meatal stenosis in women. So therefore, in these situations like this, it is very, very important that they go through a detailed external genitalia examination by a obstetrician or a urogynecology team, because that helps us to treat her many a times. Because most of the times the symptomatology in this situations will be urological causes if we are dividing into upper urinary tract infections and lower urinary tract infections. The upper urinary tract infections usually will have high grade fever with chills and rigors, and frequency, burning sensation, and reddish urine occasionally. So they generally are quite ill, very toxic looking, and they'll have tachycardia, hemodynamic instability, depending on how severe the infection is. But generally, upper urinary tract infection, they will have fever. They are quite ill and sick, and it is associated with lion pain and chills and rigors. They do not generally have a stable situation, and the cultures generally grow something unless they have received antibiotics earlier. So now it narrows down to most of the urological causes, and once we get through these things, many a times they do improve with just symptomatic treatment if they have undergone hysterectomy or a simple meatal dilatation if there is meatal stenosis. And third, and the most one of the commonest thing is the faulty urine collection, which I think Dr. Arvind Panda, our senior urologist, will be throwing more light upon.
Sir, I have a few questions for you. Based upon the information that I have given you so far, what do you think in terms of possibility of her having bacterial infection? You think like lack of response with a 3-day antibiotic and negative urine culture, is that sufficient for us to say that most likely we are not dealing with a bacterial infection? Or do you think you see it so commonly where it's still bacterial infection, but they don't respond to first antibiotic and their cultures are often negative?
It is very much possible, Dr. Anoop, that there still could be a possibility that they'll have a bacterial infection. One of the most commonest things is their failure to respond to the antibiotic, simply because the microbiological pattern in the local community is very important. And not all antibiotics in a particular, it is not the same antibiotic that you give universally. So your local antibiotic pattern is very important to define what would be the commonest cause and what is the antibiotic that would be pertinent in this particular situation. Generally, amoxiclav is something which we don't give as a first line many a times. Either if at all, if we are considering giving an antibiotic in the first place, either a nitrofurantoin or a short course of ofloxacin, or many a times nowadays 1 dose of fosfomycin is also recommended for suspected lower urinary tract infection in a community acquired infection in women.
And sir, could you please highlight, I didn't get that hysterectomy part right. So post hysterectomy, why do they have urinary frequency? Like, what is the mechanism behind?
Yeah, one of the most important thing is because they do not have estrogen, and as they keep aging, and in a person with post hysterectomy status, the estrogen is responsible for their moist in the mucosal lining. So they'll have dry genitalia and dry mucosal lining post hysterectomy because of the estrogen deficiency. Hope that answers the question.
Yes, sir, that does. Thank you so much, sir. We will come back to you with more questions. I will now switch gears. I'll ask Dr. Arvind Panda for his comments. So, sir, now we have a patient here where Praneeth mentioned that he would like to do an ultrasound abdomen or the KUB to see the anatomical features of the genitourinary system. Dr. Sridhar mentioned about local examination. I must say that I don't think any of the cardiologists would do a local examination. I don't know about general physicians. Please share your thoughts, clinical thoughts, and then also practical thoughts of what we should be doing as bare minimum when we see cases like this. Panda sir, all yours.
Thank you so much, Dr. Anoop, for having me here. I'm really honored and privileged. It's a very interesting case. It's something, as you say, we see very common in our practice. Now, this is a 64-year-old lady, and Dr. Sridhar has already mentioned about atrophic vaginitis, and she's probably postmenopausal. So now, and also diabetic. So when a diabetic patient gets UTI, it's complicated UTI. It's no longer uncomplicated. Uncomplicated cystitis is something which we would attribute to a young lady, recently married, no comorbidities. So these are the patients we can actually treat with a single dose of antibiotics. Now, coming back to this lady, I am not sure this lady has UTI. That's my personal take. Now, firstly, I would like to ask the lady, our patient, what are her symptoms? You already said that she has some dysuria and some frequency. And then I would ask whether she has any fever in this recent episode, whether she had fever previously. Now, she says she had an episode of UTI about a month back. How severe was that UTI? Was that febrile illness? Did she have flank tenderness at that point of time? And how was she treated? Now, if she had UTI, I'm just thinking aloud. If she had severe UTI at that point of time, and she had flank tenderness, and she had spiking fevers with chills, we are probably looking at pyelonephritis here at that point of time, 2 months back, or say about 1 month back. And if the lady had pyelonephritis at that point of time, oral antibiotics would not be sufficient, and we would always need to give culture-specific antibiotics for at least 2 weeks, intravenous culture-specific antibiotics. For upper tract infection, oral antibiotics are not sufficient. It has to be intravenous. It has to be culture-specific. It has to be for a period of 2 weeks. Now, many times what happens when they go to when they show in primary care, this is not followed. So maybe they give 5 days of antibiotics, in which case it is insufficiently treated, in which case there can sometimes be persistent infection in the kidney, and we all know that infection in the kidney can be very difficult to eradicate. So the first time we should treat it well, and then because of that, it can cause persistent pyuria. Now, coming back to this again, suppose she didn't have the start of UTI. Now this patient can have dysuria, she can have difficulty in passing urine and burning, all because of, as Dr. Sridhar has mentioned, atrophic vaginitis. That is, and again, about collection is about physical examination is important, because some of these patients, particularly when diabetic, can have vaginitis, and they can have fungal infection in the vulva, vulvitis and vaginitis. And these old ladies, sometimes when they're a little obese, it can be difficult for them to give a proper sample. It's easier for a thin young lady, but an old lady, it can be difficult. So most of the time when they give that sample, there is contamination from the vulval area. And if this patient has a fungal infection or some sort of vaginitis, and she's fat and she's not able to separate the vulval skin to take a proper midstream clean cat sample, we can get contamination, and it can cause, and we can get this pyuria picture in the urine. So that is something. So that is where physical examination comes into the picture, and particularly because she's diabetic, And if we have a doubt, one thing that can be done is, you ask your sister or you in the examination room, examine or clean that area with normal saline. And I now tend to put a small infant feeding tube, 6 French, and take a bladder sample just to show whether the bladder contains pus cells or not. If she had a metal stenosis, she has obstruction. Again, she can have all these flakes inside the bladder because of chronic obstruction, and which can cause pyuria. So that is one more possibility. Now, taking the collection thing apart, now what are the other possibilities that can cause this? Again, AS symptoms are very important. Traditionally, we have had three areas which have three conditions which have been thought to have associated with sterile pyuria. The most important in earlier days used to be urinary tuberculosis. Second, of course, is stone disease, and the third is a bladder tumor. To a diabetic patient who is uncontrolled, not in this patient, but who is uncontrolled, to that we may add fungal infections also. And one of the most important causes, which is often missed, is incomplete treated UTI, or the patient has been on antibiotics recently in the past or had a treated infection in the last 2 weeks. If it is more than 2 weeks, then this treated infection thing doesn't count. And many times when you do a urine culture, even after a single dose of antibiotics, the result is likely to be negative. So when I do a culture, I always ask the patient, are you on antibiotics? Have you been on antibiotics for the last 48 hours? If yes, we don't do a culture now. Stop all the antibiotics. After 3 days, earlier I used to wait for 48 hours, and now I wait for almost 72 hours. The patient is not sick. And then I repeat a culture. And then if the patient is obese, I ask my sister whom I have trained, or I go myself, clean that area with normal saline. We don't use betadine anymore for these collections. And then we put a small infant feeding tube and then take 10 ml or 5 ml of urine for a culture and a CU and a urine microscopy. Now, coming back to if we suspect urinary tuberculosis is never isolated pyuria alone. It is pyuria with hematuria. Always there will be red blood cells if you are looking at urinary tuberculosis. And also UTI also, many times it is associated, in fact, the majority of the times associated with red blood cells in the urine. And all of these patients, when you're suspecting tuberculosis, will have bladder symptoms, frequency, urgency, nocturia. And it'll be very severe frequency. Because there is a lot of cystitis in TB. So the patient will say, I get up, doctor, I get up 20 times to pass urine. And this will not just be frequency, it'll also be nocturia. So even in the night, I cannot sleep. I'm actually getting up 15-20 times and I have these small voids. So one of the, again, just to small digression, one of the things about organic versus psychogenic frequencies. In psychogenic frequency, once the patient goes to sleep, you don't have frequency. But from something like tuberculosis, the patient is very likely to have severe nocturia and frequent nocturia throughout the night. And coming back to, and then after this, because she's diabetic, I would always get an upper tract evaluation. Generally, upper tract evaluation is ultrasound is generally enough. But if I feel sometimes that this pyuria has been persistent, I would get a CCT with and if the creatinine is normal, I would get a CCT with delayed films. So that would give us some more information. It would give us if there is perinephric stranding, if there is any papilla which is necrosed and is hanging around and it's causing the pyuria. It'll give a lot of information to us. If all of these are normal, then I know, and she doesn't have much, no stone, no bladder tumor, no electric mass, no papillae, no fat stranding, then I would get a uroflow. Uroflow, again, I would get it before the CT. Uroflow would actually tell us about her flow. Normally, even in an old lady, 64, that should be a reasonable flow. It should not be a flat curve. A flat curve indicates meatal stenosis or some sort of obstruction. And I would also try to get a post-word residual urine to see if if some of the urine is staying behind in the bladder. That also helps. We can actually treat. So this is what I would initially do, and I hope after doing all this, I would be able to get some sort of diagnosis or some sort of differential diagnosis. I would like to corroborate my differential diagnosis after these investigations. I would take some questions because I think I have gone on too long. If there are any questions, I would like to take them before I proceed further.
Arvind sir, I have a lot of questions, and you have not taken much time because we are here to kind of listen to your thought process. So if you need to take another few minutes, you are more than welcome. So questions I have for you. Just you mentioned about contrast CT in these kind of patients.
Yeah, after I finish, yeah, please, sorry.
Right. We are very concerned whenever there is any question of genitourinary involvement, either in the form of UTI, even uncomplicated UTI, whatnot. We are very scared of exposing them to contrast, even with a normal creatinine. Is that something which is this fear validated, or you think we are just too concerned about it?
No, this is a particular patient. This coming back to this particular patient is one thing that we would be, one is she is diabetic. She had an UTI before. She is having sterile pyuria. Her creatinine is more or less normal. So this is, and I'm sure she had ultrasound, which was more or less normal earlier during the UTI. And if the flow is normal, then I would consider this contrast CT. Because that would allow me to see both the perinephric fat standing and because when you are looking at pyuria, you want to see the mucosa, you want to see the ureter, and you want to see the bladder contour. If I feel if the creatinine is normal and we hydrate the patient well, it is not so much of a risk to do a contrast CT. We are using non-ionic contrast nowadays. And with this newer CT protocols, now we don't have to give a lot of contrast or a double dose contrast. Dr. Sridhar Reddy would be in a better position to answer this, but I would not hesitate if the creatinine is normal. And I will hydrate the patient maybe before that. She should, and the diabetes, of course, should be well controlled.
And sir, you mentioned about at least a few investigations, or at least a few approach in these kind of patients. So when, let us say, if I send this patient to you at this stage where she was treated once a couple of months back, at that time there was no febrile illness, but there were similar symptoms. We don't know what she was treated with, but 2 months back she was treated. Now she's having on and off symptoms for a month. 3 days of oral antibiotic didn't do anything, culture negative, few pus cells, no blood. So at this point of time, if this patient comes to you, you have already mentioned that tuberculous cystitis would typically have blood in it.
Yes.
My guess is even nephrolithiasis would have some blood in it. That's my guess.
Yes.
And
yes.
I don't know about
You're correct.
I don't know about the tumor aspect of it. So if a patient
Tumor also would have some blood, sir. Tumor also would have some blood. Not always, but usually. Not always, but usually.
So when these kind of patients, when they come at this stage, do you escalate the workup to what you have described right now, or you say that let us do some more trial because common things are common, and let us try one more UTI treatment, or you would go through what you said, get a proper examination, get a bladder sample and those kind of things? Are these routine things to do, or these are special cases which you do once in a month?
Sir, this patient, I'll be doubtful if she ever had UTI. If she doesn't had, if she never had fever, and she was treated with antibiotics more than once, it hasn't made a difference in her, I would be skeptical. My first thing when I get these patients is I think in my mind, okay, we are probably not dealing with the UTI. If it's UTI, very nice, it's easy for me, but let me look at all the other possibilities also in my mind. So for me to take a blood sample, sir, it's the same process, the same money. It doesn't cost anything more in my OPD. I just send the patient to our room, to our examination room. Sister is trained. All that they need is an infant feeding tube and some normal saline with the sterile gauze. They clean the area and they take a sample. And I feel in old people, this is a better and most cost-effective method than, putting them into multiple cultures. We take one culture, repeat, treat, again take a culture, repeat, because culture is far more expensive than this. This doesn't cost much money. So that is something I would do. I would get if a ultrasound has not been done, I would get an ultrasound and a uroflowmetry, and I would look at the sugars, and of course I first initially done a good physical examination. This is my basic workup. If after all this I am still getting sterile pyuria, and I know it is sterile pyuria, and nothing else, I would not hesitate. And the flow is good. Flow is she has a good flow, and I know it's not obstruction. Then I have ruled out a lot of things. In that case, I would go on to do a CT scan, because sometimes, small mucosal lesions, small tumors, you can miss with an ultrasound. The entire ureter you really cannot see with the ultrasound. So that is something I would go on. So, but then if I don't get sterile pyuria at that point of time, I will be looking at interstitial cystitis, painful bladder syndrome. There are a lot of non-infective causes which can cause all this dysuria, and we can treat with antibiotics. It is not going to help. So in those cases, I would treat differently. Once I've ruled out the infective pathology, I ruled out tumor, I ruled out everything else, I would look at interstitial cystitis, painful bladder syndrome. I would treat them on those lines.
Sir, what is the risk of increasing the infection, as in causing retrograde UTI, if you are doing infant feeding tube and collection through that?
Sir, we clean that area properly, and we just put it right into the bladder and aspirate 5-10 ml and take it out immediately. So I don't think it'll cause any infection. And even it is hardly. I have never had that thing. The other option which is described is to a suprapubic sample. Then a suprapubic sample, I used to do it earlier very frequently, but now but it is painful, and patients don't appreciate, and occasionally it can cause bleeding. And you need a spinal needle for it. The description was to do a suprapubic sample. I don't do that anymore. I have stopped doing it for close to 5-6 years now. I used to do it earlier because when I want a properly collected sample. So I have been using this technique, and I have had no issues whatsoever in all these years.
And
but again, it's very important that you stop antibiotics for about 72 hours before you do a culture. Otherwise, there is no point.
And sir, is this patented to your clinic only, or most of the urologists do that?
I don't know about, sir, but a suprapubic sample or a catheterized sample is done frequently. I don't know if other people do it in Hyderabad, but throughout the world it is done. That I can tell you. Not a problem, because when you are suspecting a improperly collected sample, a properly collected sample is a catheter sample or a suprapubic sample. This is done throughout the world, and even in my old institutions we used to do it. And now that Vellore we used to do it. It's not much of a risk, sir. It's not much of a risk. It doesn't cause any infection if it doesn't have, because again, infection is not something that can happen if you clean. Just put it right inside the bladder neck and just take 10 ml. It's not going to happen. No. Because you're using a new tube, using a new tube, you're taking all the sterile precautions, you're using a sterile gloves. It will not happen.
And sir, what I am understanding with your description is that this is not a service that anybody or any doctor like me practicing, or I'm sure most of my attendees, it's not a service where they can simply order in their hospital, right? They can't order that please obtain sample through infant feeding tube.
Sir,
it has to be
yes, you are quite correct. And there's one more thing that I want to emphasize. I always emphasize is when we send the patient to say, sir or madam, you go to the lab and give a sample. The lab person does not give any advice. The lab person, if I have seen this so many times, I've gone down to the lab and I've just stood there to see what they're saying. They'll just give the bottle to them and say, give a sample. Somebody may say, give the middle sample. Now we need to educate that patient before the patient leaves our OP room. See, we need to clean that area first, make it dry, sit down, separate the skin. Or in case of a male, I tell them during the examination when I'm doing, take your skin back like this, take the prepuce back like this, clean the area, make it dry. Then again, take the prepuce back, pass urine. First part you discard, middle part you give for testing. This can solve majority of the problems. Always you don't need an infant feeding tube sample. I do that only for old ladies who are very fat, who cannot really sit. They need a Western commode to sit. In that case, it's very difficult to give a sample like this. So this is the first part. Second part, we need to make sure is that the sample so taken is plated within 1 hour. If you look at all the microbiology texts and if you look at the guidelines, a urine culture must be plated within 1 hour. If we are not plating within 1 hour, we have to store in a special, we have inside the fridge or something. but that's not ideal, because more than that, sometimes what happens is two things can happen. Either a low colony count can die out, or a high colony count can sort of multiply. You can get multiple organisms. So it is important. It is important when we are giving a culture that we do it in an area where it can be easily sent to the lab and plated. I do not support, and I strongly discourage my patients from giving urine culture samples from home. I say, see, if you want to give a sample, you are welcome, but you go to the lab and give it there. Don't give it at home, because the home collection fellow will go around another 5-6 places, maybe give your sample after 5 hours, and then there is no point. It may not grow anything. So these are the things which you need to keep in mind when we are giving a urine culture. And always have a hotline with the microbiologists, and whenever there's a doubt, you can pick up the phone and call. I think that's also very important.
So my last question to you is, in particularly females in their 50s, 60s, or maybe even elderly, if you could just give us an idea about the difference in value that urologist adds in these kind of clinical presentation versus a urogynecologist. We have gone into this fancy term of, let us refer it to a urogynecologist. I have no idea how to differentiate a urogynecologist with a urologist. Is it a different branch altogether, or is it a urologist on gynecologist? Is it a gynecologist on urologist? Please enlighten us on that. I hope
Yes,
that is not a very stupid question.
No, sir, it's a very relevant question, and it's a very delicate question. I just like to say one more thing. All these old ladies, when they come to you and they complain of burning, please don't hesitate, if they're post-menopausal or post-hysterectomy, to prescribe them an estrogen cream. Just tell them, this is the important point in practice, estrogen cream. Tell them to take a little bit of estrogen cream in their fingers, and they put it in the vulval region and around the meatus and a little bit around the vagina. One of the, as Dr. Shidhar Reddy already has mentioned, one of the most important cause is atrophic vaginitis. They have pain, they have dysuria. If estrogen cream can really create wonders. What happens in the premenopausal age group, you have these commensal bacteria there, and these commensal bacteria prevent UTI. So many of these ladies, once they become menopausal, have UTI. They never had UTI in the past, and they suddenly have UTI. The reason for that is now because that atrophic vaginitis, the old bacteria, the sort of commensal bacteria, they have died out, and they have been replaced with more pathogenic bacteria from the gut. So if we replenish the estrogen cream locally, these old bacteria will come back, and this pathogenic bacteria will be driven out. And this is very simple, and local estrogen cream doesn't really cause the sort of side effects which the oral estrogens cause. No cancer, all those things, is much less. So it can be given indefinitely. They can take 4 or 5 days a week, no need to take every day, and they can continue. In my opinion, they can continue for even 1 or 2 years, no problem. There is no issue at all. Coming back to a very pertinent question about urologists, urogynecologists. Sir, urogynecologists, most of the urogynecologists are actually gynecologists who have wished to practice some sort of female, specifically female prolapse, or female pelvic organ prolapse, or sometimes dysfunction. Most of the urogynecologists who are there now in practice are actually gynecologists. There can be urologists who, with a special interest in functional urology and female urology. That's one of my interest areas. So that is a separate, but I don't call myself a urogynecologist. I'm a urologist with specific interest in functional and urethral reconstruction and female urology. So it takes a knowledge of the bladder and the functional thing and its function. I feel to do justice to it. It's not just about prolapse. So I am very controversial in this area. So I think I will leave it at that. It's a very delicate situation.
So my purpose of asking this question to you is, when patients come to us, we often need to decide whether we should be sending the patient to a urologist or whether we should be sending a patient to a urogynecologist. And the line where I draw, and that is not based upon any expert opinion or whatever, that is just my thought, that the line I draw is whenever the patient complains of some anatomic defect that she can appreciate, then I send her to a urogynecologist, versus if it is only just these kind of clinical presentation, I send to urologist. Can you give us some hint, or can you give us some features which if present in the patient, we should be talking more towards gynecology versus more towards urology. Can we differentiate? Is it possible?
Yes, sir. Actually, if you are talking about pelvic organ prolapse, cystocele, rectocele, if you're talking of those areas, then you must say you should send it to a urogynecologist or a gynecologist who deals with these things, because they are better off doing the prolapse part and they're better off doing that part. But if you're looking at female urethral obstruction, you are looking sometimes at stress incontinence, you're looking at UTI, and you're looking at functional disorders of the bladder, like interstitial cystitis, then it is much better to send to urologist who deals with such things, because it is just not about treating the infection, it's also about treating the whole person, and also making sure this doesn't happen again. Because again, a diabetic patient, if you have got an infection, if you have treated the infection, ruled out any sort of functional disorders or anatomical obstruction, and she's having recurrence, it is worthwhile giving a low dose prophylaxis for maybe 3 months with nitrofurantoin or something like that. This is something, again, I think I made it more or less clear. If you are looking at prolapse, you send it to the urogynecologist. You are looking at other things which are more functional, you might well as send into a urologist.
Thank you so much, sir. Those were the questions that I had for you. If anybody in the audience has any questions for Dr. Arvind or for Dr. Sridhar, or if you want to share your thought, you can raise your hand or unmute yourself. Praneeth, you have a question?
Yeah. So, sir, you mentioned about the CT protocol for this thing. Anything specifically that we need to mention for this CT scan, sir, or you would be referring it? We should refer to you, and you will get it done.
No. If you want to do, you can do it. Just ask them to do a delayed film, because when you're looking at pyuria and you want to see the entire ureter, you want to see the entire bladder. So delayed films are essential. So it fills up the collecting system and it also fills up the bladder. So you are able to see the entire bladder wall. You are able to see both ureters completely. So delayed films is required. Otherwise, nothing specific. Yeah, for nowadays, because everybody is giving non-anic contrast, I think that is not a very particular thing. And you tell the patient to drink plenty of water. Yeah, I wonder if Dr. Sridhar Reddy would like to add something to the CT protocol that for safety of the kidneys. Dr. Sridhar Reddy, yes, please.
Sridhar, sir, we will come back to you to answer this question. But before that, Praneeth, was your question answered?
Yes, it's answered.
Okay.
Just one more thing I want to add about antibiotic protocol. We did in KIMS, I have last 2 years, we have done a study in nephrology and urology both to see our OPD, we have seen our OPD patients come in with UTI. So we have sort of documented all these cases. And unfortunately, we have found that most of the infections who come to at least to our OPD, uro and nephro, they are complicated. They are complicated in the sense they are multi-drug resistant infections. And there is only a 70% sensitivity for even meropenem. And Ciplox and quinolones, this is less than 10 to 20%. I can share the data with you if you wish for my OP, for uronephro OP at KIMS.
Sir, we would really appreciate if you could share that data with us. I will share it with my Huddle audience so that they also see what is the pattern which is there in our community. Dr. Rahul, you have anything to add? Please unmute yourself.
Hi, Anoop. Hello, sir. Hello, everyone. Wanted to ask one question here, sir. How frequently have you seen drug-induced cystitis presenting like an infection or a sterile pyuria, particularly with the new drugs which are given for anti-obesity herbal medications and SGLT2 inhibitors?
Sir, SGLT2 inhibitors I can always talk about, and I would like this. We see a lot of hemorrhagic cystitis in patients who are on chemotherapy, sir. Particularly chemotherapy, many of the cyclophosphamide, even some other drugs, they cause hemorrhagic cystitis. So once we are called there and there is sterile pyuria and some hematuria, we know it is hemorrhagic cystitis. For the newer drugs, herbal medications, sir, I am sure that I don't have much experience. I haven't seen. SGLT2 inhibitors are causing, I know I am among cardiologists now, and they think it's a wonder drug. I know it's a wonder drug. It's something that takes off the water without taking out the electrolytes. But for me, as a urologist, and Dr. Sridhar Reddy also will not agree. He also likes the drug. As a urologist, I am a little skeptical about it. I know about the papers which have come, which shows a sort of significant improvement in mortality and in its advantages in CCF. What I have been seeing, I'm biased because I'm only seeing the UTIs. I have seen an increase in number of UTIs, and it's very difficult to treat these UTIs once they are on SGLT2 inhibitors. We have to stop. So I make it a point to ask my clinical assistant to ask everybody who is coming, are they on SGLT2 inhibitors if that has circled? Second point is, in old people, it is causing nocturia. I know there is not much data on this. We could probably plan a study. So these are the two things. SGLT2 inhibitors, if you're suspecting UTI, we have to stop. And then, maybe give some other something else until is controlled. And in these patients, I would recommend don't restart. But then it's up to you. You have to take care of the heart as well.
Is there any way of doing an eosinophils in the urine or eosinophilic test to know whether it is drug induced versus infective?
Sir, it's a good question. Eosinophils, no. What we can do is we can see whether it is there are if there are a lot of red cells, we can do a phase contrast microscopy to see whether these are medical cause or a surgical cause. A surgical cause will have complete RBCs. A medical cause will have sort of ghost cells. But eosinophils, as far as I know, no, we don't know. But again, drug-induced cystitis will have significant eosinophilia. And I have got after biopsy, but we have had patients which have got very small bladders, and they had no tuberculosis. And then when we did a cystectomy and did a ILL, we had to do a diversion. So the bladder was actually so small. The biopsy in 2 patients have shown a lot of plasma cells in the detrusor muscle, suggestive of eosinophilic cystitis.
Okay, so thank you, sir.
Thank you so much. Thank you so much, sir. Sridhar, sir, if you are still online, maybe I can ask a couple of questions to you.
Yeah, please, sir. I'm there.
First of all, this contrast and the CT in UTI, are you worried we are going to eat up some more nephrons, or you think if we hydrate and do well, it's okay?
Yeah, it all depends again. I think once we have decided, and if we have a concrete reason to do it, yes, we should. In fact, I would not say in terms of going that far in a person with sterile pyuria with very minimal symptoms. I would reserve that towards as a desperate situation to define a anatomical abnormality. And when we are administrating the contrast, then we go through the same protocol and tick all the boxes, like their diabetes is well controlled and they are not on ACE inhibitors, ARBs, and they are not on NSAIDs, hydrate them well, and then make sure that their kidney functions are all right before giving contrast. And yeah, so I hope that answers your question.
And sir, one question which is put up in the chat box: is there any role for prolonged antibiotic treatment for 1 to 3 months in recurrent UTI, particularly after prostate surgery? I know that suppressive antibiotics with nitrofurantoin are given, but are there any role of prolonged antibiotic treatment?
In prostate surgery, I assume that you have asked me a pertinent question of recurrent urinary tract infection, which is symptomatic after prostatic surgery. Then yes, there is a role for low dose prophylactic antibiotics for preventing severe urinary tract infections. Dr. Arvind Panda would throw more light if it's a post-prostatic surgery.
Panda sir, could you answer that question? Prolonged antibiotic in recurrent UTI with or without prostate surgery?
Sir, if the patient has risk factors, we are talking of complicated complicated UTI here, not simple UTI. So if the patient has risk factors, like she is diabetic or he is diabetic, and he has got prostatitis, that is because these, or he has got pyelonephritis, he or she has got pyelonephritis. Prostate and the kidney are unique organs in the way that once if they are colonized, it is difficult to take the bacteria out. It can be quite difficult. And one more thing about the prostate is that very few antibiotics penetrate the prostate. Quinolones penetrate, sulfa penetrates, and not many other antibiotics penetrate. So in these patients and those who have uncontrolled diabetes or something, after clearing the antibiotic, after clearing the infection, I will make sure that I repeat a culture of antibiotics to make sure that is actually no growth. After that, I would give a low dose chemoprophylaxis for 3 months. And my preference for it would be something like a like a half tablet of Bactrim DS, or I would give something like trimethoprim. I would not give nitrofurantoin to the patients whom I want tissue penetrations, because nitrofurantoin is basically urinary antiseptic. It has very little tissue penetration. But if I'm looking at only a diabetic patient whom I don't want, who had just didn't have pyelonephritis but have recurrent infection, those patients will benefit from nitrofurantoin, because you really don't want tissue penetration. You want something to give in the night. So because in the night, when the patient doesn't void, that is the time when bacteria tend to multiply. So if you give it in the night and there is some sort of antibiotic in the bladder, urine, the bacteria will not multiply. Morning, the patient will void out, and that's it. So that is the concept. So we can give for 3 months to make sure whatever little bacteria is there will be taken care of by the body defenses in 3 months, and then we can stop. At the same time, you can start the controlling the sugars, etc., and lose weight. All those things can continue. After prostate surgery, I would tend to treat. I would not tend to suppress, because after I've done a TURP, before TURP, I would give culture-specific antibiotics. Post TURP, after the catheter removal, that's very important. After removing all the foreign bodies, I'll give 3-4 days, repeat a culture. If that is negative, I might sometimes give, if the biopsy particularly showing sort of lymphocytic infiltrate. Otherwise, I would wait if there is a redo of a culture before giving, because if we give more antibiotics, we cause more bacterial resistance. It's not always good idea to give without reason.
Thank you, Dr. Panda. At this point, I would invite Dr. Somaraju for his comments for today's discussion.
Thank you, Anoop. It's a more learning experience for me. But having said that, just like many other areas in medicine, this is an uncertain area. Too much of generalization, too much of trying to think that you have answers for all the situations in these patients is fraught with mistakes in management of these patients. You have to, we have subsets of patients and they have to be addressed individually, and there are uncertainties. In these situations, I think the clinicians concerned, that includes a physician or cardiologist or urologist or a nephrologist or gynecologist, as the case may be, should meet together once in a way in a difficult situation and make decisions. The answers are not straightforward, as sometimes in the last 1 hour I heard too much of trying to make it look like simple is not right. Thank you.
Thank you so much, sir. Anybody else has got any other comments or questions that we can take over the next few seconds or maybe a minute before I start winding up? If not, Praneeth, your closing comments for today's session?
Yeah, so I agree with what Somraju sir said, that this topic looks like a simple urinary tract infection, but the way the discussion happened, there is a lot of things which I have learned today, starting from trying to make a distinction whether it is truly an infection or not. Post-menopausal women can have an atrophic vaginitis which can mimic a urinary tract infection, and the the suggestion of using estrogen creams, which are probably not harmful, but may help relieve that dryness and may help relieve the symptoms. The apprehension of having a urinary tract infection is gone. Now, if there is a urinary tract infection, to make an diagnosis, the most important investigation being a urine examination or a urine culture. The importance of collecting a urine sample, a clean catch urine, a fancy term which we read in textbooks, but practically it is not frequently seen. The concept of cleaning the area with a saline and collecting it with a infant feeding tube seems to be a very attractive technique to get a clean catch urine, and I believe most of the unnecessary investigation or duplicate investigations can be avoided in that. Then to consider whether it is a simple UTI and complex UTI, I like the statement that any diabetic patient who has a urinary tract infection should be considered as a complicated UTI and should be taken seriously. The role of investigation, starting from a simple ultrasound abdomen to CT scan with delayed films, to look at whether there is any anatomic obstruction, and a detailed examination, probably taking help from female colleagues, be it a nurse or sometimes a gynecologist, particularly looking at meatus stenosis, which I understand seems to be pretty common and could be one of the reasons for recurrent urinary tract infections. And considering other infections like fungal infections is also pertinent, but when in doubt, it's always better to refer to a specialist, where there are other etiologies as well in terms of tuberculosis, cystitis, or tumors, or any other anatomical issues. So I believe having a word with a urologist or a nephrologist is probably worth the consult. So I think there are a lot of things which I learned. Another interesting point was about uroflowmetry, which is again something which I learned, that uroflowmetry I believed was only restricted to men, but it also has a significant role in women, is what I equally understood. But all in all, there are so many things, but this common clinical scenario with this discussion, I think we can do better justice to the patients, being the so-called non-nephrology or non-urological physicians or specialties, if I have to count. Those are my comments, Anoop.
Thank you, Praneeth, and thank you all of you for attending today's session. It is 9:07, so we're about 7 minutes out. I would be closing this session, and I thank all of you for attending today. Particular thanks to Dr. Arvind Panda and Dr. Sridhar Reddy for joining me today. As you all know that we do this discussion every Wednesday at 8 p.m. and the link for joining is the same as what you use today. So if you want to join the future sessions also, you can use the same link provided. All the podcasts, all the sessions now are recorded and are getting uploaded on podcast. And we are about 95% complete for YouTube as well. Maybe in the next couple of days, I will get all the sessions uploaded on YouTube. So you can use your dead time to listen to some of the previous discussions that we had. Thank you all of you again. Good night, and we'll see you next Wednesday.
Thank you so much.